Thank you everybody for joining this session. Today is the second open house on the National Health Stack. There are three of us again. There is Kiran Anandampillai, you met him last time, and Siddharth Shetty, he was also there last time, except this is a slightly different formulation. This time I am the moderator. My name is Sharad Sharma, and I'm one of the volunteers at iSPIRT. So with that, I'm going to have a few kind of opening remarks and then get started and hand it over first to Sid. The first topic that we will cover is answer your technical questions on the personal health record, PHR, which was the subject of last time's discussion. And then we will shift over to discuss the doctor registry, and that would be covered by Kiran. So these are the topics that we have. Before we get started, there are a couple of overviews. Our standard overview of iSPIRT, which is a non-profit technology think and do tank, and we are powered by volunteers. We call ourselves No Greed and No Glory. We are doing this as part of nation building, ecosystem building. Our fundamental premise is that India's hard problems, including health, can only be solved by a jugalbandi between public infrastructure and private innovation. So public digital infrastructure and private innovation. So our goal is to bring this kind of an innovation architecture to life and solve some of India's hard problems. A very quick recap of the health stack. We had shared this slide last time. There are in the health stack 3 layers. There is a plumbing layer. We will be discussing personal health records today and electronic registries, particularly the doctor registry today in detail. Then there is a middle layer. We'll be covering that in future sessions of the health stack. And then there is a top layer, which is called Ocean. Ocean is the Open Health Services Network. And in the coming sessions, we will be covering, before we cover others, we'll be covering this teleconsultation Ocean APIs, and that will come up. So these are the topics that we'll be covering. The roadmap for this is here. We are sharing this with you now. As you know, the APIs and sample code for PHR was shared last time in the last Saturday session. You must have all seen that. We are doing a technical Q&A today. This is part of that discussion. We expect that the test environment for people who want to go live will become available on 30th June. So if you have started implementing either a health information provider, health information user, or a consent manager, you will be able to test it against a live environment on 30th June. Certifications will start in July, and after that, you can go live in the market for that. We're going to cover the doctor registry today. The APIs will be released on 8th of June. Test environment will go live on 15th of June, and the registry is expected to go live by end of June. As I said, there is this Ocean layer that we talked about, Open Health Services Network. And the first focus is on teleconsultation APIs. This APIs and sample code is likely to be announced towards end of July. And then things will move very quickly. The test environment will go live in early August, and by middle of August, there'll be a relatively quick certification for this, and that would happen by middle of August. So this is really the lay of the land. These dates may change, and if they do, we'll keep you guys informed. So, so that's really what I wanted to cover in the beginning. And with that, I'm going to hand this over to Sid to cover the Q&A on personal health records. So over to you, Sid.
Awesome. Thanks, Sharad. I'll just share my screen. One second. Okay. present.
And maybe Sid, before you start, a housekeeping announcement. In the chat box, you will see that there is again a link available where you can submit questions. These are questions that we want to live from one session to the next. And so please post your questions on that link, and we'll try and take as many of them that we can today. So today, many of the questions that Sid is answering are the ones that were submitted on this link. Thank you.
Thanks, Sharad. So essentially what I did is the questions that came in last time around and during the course of the week, I've kind of triaged all of them, and a lot of them had similarities. So I put together a list of the 10 most important questions that were raised, and I'll go one by one and answer each of them. The first one was, how does one really connect to the network? So if I am a health information provider or a custodian of users' data, either as a hospital, as a lab, as an individual clinician, how do I connect to the network? If on the other end, I want to consume this data as a health information user, how do I raise consent with my with the patient, and then how does the patient approve it? Through what consent manager? How would that flow work? And who are the API bridges that I can talk to if I want to make these integrations happen? And this is a recap of the overview, the technical overview that I shared last time. So the way it would work, and the best way to think about it is, if you're a health information provider or a health information user, let's start first with a health information provider. So you're a custodian of users' information. Then to connect to the network, that needs to happen via an API bridge. So if you see out here, essentially the API bridge or data bridge on the southbound end talks to the ecosystem through the standardized set of APIs. But of course, on the northbound end, those are non-standardized APIs, and that is what providers of API bridges can innovate on. So some software providers of an API bridge may offer a PDF upload facility to small labs and clinics. Some API bridge providers may offer a really neat developer experience with libraries in various languages. Some may offer cloud solutions, some may offer on-premise solutions. And that's what the ecosystem of API bridge providers will innovate on. So if you are an HIP, you can either connect to any API bridge that's out there. Or you may also build it yourself. Given that the interfaces have been standardized, you could say, hey, I will build this myself internally. Both are available options. Now, getting into the specifics of it, right? And we'll send these slides later, and this is the same set of URLs that I shared last time. But the functionality of an API bridge for health information providers is very simple. Essentially, you need a way to facilitate the discovery request, the linking request, the consent request, and subsequently the data flow, right? So discovery is, you will receive a set of user identifiers, which you will then match with your internal system and return back a mass list of identifiers to the network that then shows up on the consent manager app. Linking request is when the user now wants to authorize the linkage between the health information provider and the consent manager. So through some token auth, either could be an OTP that an HIP sends to the consumer. It could be an OAuth like flow and others. The HIP authenticates the user and authorizes the linkage. The third piece is the consent functionality, where you receive the consent artifact, and then you will need to verify that consent artifact, verify its digital signature, validate it, check whether the user had linked their account. And if all those checks work out, then fetch the data from your internal data store, and then encrypt it, sign it, and pass it back to the HIU, which is the endpoint you would have received in the API request. So therefore, it's very simple to get enabled as an HIP. And you just need to build out this for functionality. Now, of course, people may decide to offer this API bridge as a SaaS offering to HIPs that don't want to build it out. And that's also an opportunity for many of the folks on the call to build this either for developers or for other system integrators / ISVs to use and then connect with the long tail of health information providers. On the HIU side, you also need an API bridge. So the HIU is on the right-hand side, right? And this is the entity that's consuming the user's data, let's say as part of a teleconsult, right? So you raise consent, you receive the user's data. That also happens via an API bridge. Now, the functionality of the API bridge out here for an HIU is, again, very simple. It needs to facilitate the raising of a consent request, and then it needs to facilitate the receiving of the data from the HIPs, because it exposes out an endpoint to receive that data. And once it receives that data, the API bridges may provide additional functionality of various ETL on that data to either offer a combined view. So if that data comes from multiple providers in different schemas, then an API bridge provider may actually combine all of it into one common schema and then share that. For the HIU side of things, the same principles apply. So the southbound APIs are standardized, and that's what I had shared with you last time. But the northbound APIs haven't been standardized. And again, that's where the software companies can innovate on by offering different integrations with the lab information management systems or the hospital information management systems. It could be custom, or it could be ready-made adapters, and so on. So it's fairly simple to get up and running as an HIP and HIU. Broadly, my sense is it should take 2 to maximum 4 weeks if anyone's interested in being an API bridge for HIPs and HIUs to get up and running. And then, of course, you can keep layering on more and more functionality. The URL out here outlines the interfaces, the southbound interfaces that you will have to build out if you're aiming to offer your API bridge either to HIPs or to HIUs, respectively. The second piece is on the consent manager front, right? So the consent manager interacts with the consumer out here and offers an informed consent collection experience. If you look at the functionality that needs to be offered by a consent manager app, it's broadly providing a user interface for facilitating the discovery and linking flows. Second, providing a user interface for showing the consent request to the user and showing it in an informed enough manner, and that depends on which user segment one is targeting. And then allowing the user to approve that request, reject it, and then showing an interface to the user where there is a log of the consents that they've provided. They can revoke if they've given recurring consent, and so on. I mean, these are the most primitive interfaces that are offered. The reason I call it an interface is because different consent managers would target different set of users. So some consent managers can say, hey, I'm creating a completely self-service experience for my user. Some consent managers can focus on creating an assisted experience for the user, right? And some may even offer it through other non-multimedia forms, like say an IVR call and so on, or through an inbound and outbound SMS as well, or USSD. So it really depends on the user segment that the consent manager is targeting. And we don't restrict any sort of innovation out there, because those northbound APIs and interfaces are what different consent managers can innovate upon. For the southbound interfaces, you can use this link and see what all APIs you need to use to talk back to the gateway. And if you want a reference gateway to start off and see discoverability of requests, routing of requests, if you're building out a consent manager, then there is an open source one that's up and running. Since the interfaces have already been defined, you can, again, build your own gateway or use the one that's already out here. And the same applies for the consent manager app. So if you're building out an API bridge for HIPs and HIUs, and you don't want to build a CM app, then you can use the consent manager app out here to simulate those requests and get started.
So before we go to the next question, one of the questions we get is, why should we be an HIP, HIU, or should we be a consent manager? What's the business justification for this? As we had mentioned in the last session, these are technical sessions at this time. This is voluntary, whether you want to do it or not, we understand is a business decision. In one of the future sessions, we will cover the business motivations, the business benefits, the business model for doing this. We want to do that after you have a very good understanding of the technology infrastructure here, and then come to that topic in one of our future open house sessions. So this is not something that we will be covering today. So keep that in mind.
Thanks, Sharad. The second question that we got was the registries that you saw on this diagram, right? How do those work? What is it for? What is its purpose? And how does it relate to even the other registries in the national health stack, like the doctor, provider, drug registry, and so on? So the way to think about it is the registries are a key part of discoverability for health information flows, and discoverability from the point of view of endpoint information and certificate information, endpoints of the API bridges, and then certificates of the different entities in the system, because the request responses and the data is digitally signed. You, of course, have a set of functional registries that are required. For example, the facility registry, the doctor registry, which Kiran is talking about later in today's call. But that is out of the health information flow ecosystem, right? So what's part of the health information flow ecosystem from a technical point of view is really the consent manager app registry and the bridge registry. So you can think of this as a version of DNS, right? And these registries are hosted by the gateway. And we've also defined a schema for these registries. So the consent manager app registry is nothing but every CM app, right? Firstly, there can be multiple gateways to facilitate the routing of consent. Data never flows through the gateway. Data always flows from the HIP to the HIU. But every consent manager has to register with one gateway, and that's their choice, whichever one they may choose. But when it registers with a gateway, essentially this information then gets captured in the consent manager app registry, which is meta information of the consent manager. So it's name, unique ID, a particular namespace is allocated to it, because remember in the last session, like I showed you, it could be the consent manager was NCG. So you had the namespace at the rate of NCG. And so whenever I gave my consent handle to an health information user, let's say the doctor for a teleconsult, I gave them Siddharth at the rate of NCG, right? So that namespace. And then of course the certificate information, which is then subsequently used for validating the digital signatures, and then other transactional related information of whether it's been blacklisted, whether it is still active with a timestamped audit trail. And much like you have the list of consent managers being accessible in the registry, we also need a list of API bridges in this ecosystem. And so a similar schema has been defined for them. Meta information about the API bridges, their digital certificates, and then the different health information providers or the health information users that are hanging off of them, right, are made available. And the key part, the entry criteria for being a part of this registry is essentially the certification process, because every entity needs to be certified against both functional attributes that are relevant for interoperability and other reasons, and non-functional attributes like high availability, scale, and security, and so on. And therefore, once they complete their certification based on those standardized set of test cases, they can then be added to the registry. And these are the two registries that are hosted by the gateway and publicly accessible to anyone in the network. So then you can look up that registry and send a request accordingly. The third part was, so we got a lot of questions on schema standardization. Why aren't we getting started with using international standards like LOINC, SNOMED CT, and other HL7 defined standards like FIRE and so on, right? And what was the overall thought process regarding moving towards a standardized vocabulary set? So our view is actually, and we're doing it inverse of the way it's been approached in a lot of other geographies. And the reason being, a lot of health data and consented sharing of health data projects worldwide have failed because they all got hung up on first attempting to standardize the schema. And that, especially in India, given the diversity, given the different vocabularies that are used, both by hospital providers as well as by diagnostic labs, attempting to create a nationwide common schema right at the get-go and using that as the first factor to go live is actually next to impossible. None of it exists today. And therefore, our belief is that we will first start off with a schema-less approach where the core plumbing is laid out and the user can authorize consent and then share that non-standardized health information with a HIU. At that point in time, the API bridge of an HIU can offer extended functionality of combining these different non-standardized documents into a common viewer, right? Or they may also choose not to combine it and just show the different PDFs, for example, to the HIU. And that allows the ecosystem to get started. The next phase we see is essentially moving towards what we call an embedded schema, where every HIP and the HIP's respective API bridge embeds the schema of that document when they share it. And this embedded schema then allows the API bridge of the HIU to combine it a lot easier because you can look up that schema, understand those attributes. And then we see convergence towards, in phase 3, a common schema being created. We have already kicked this off, a prototype of this for diagnostic labs and diagnostic lab tests. And if you're interested in being a part of the data dictionary that's being created, please do reach out. Where in the case of diagnostic labs, while a bunch of folks are already coming on board, adopting the schema-less approach, what we do know is that for interpretability on the app side, on the HIU side, for easier consumption, if there is a common data dictionary, it makes adoption a lot quicker, a lot faster, and a lot easier. And if there's also a common data dictionary, then all new software systems that are being put in place by labs can actually reference that data dictionary. Today, say labs in smaller regions actually reference a data dictionary of a larger lab in a city, right? And as a result, when the larger lab changes its schema, then the smaller lab has never changed it. And so we have a multiplicity of schemas and variables out there in the market. And so we are first starting this off with diagnostic labs and creating a common vocabulary of that. Think of it along the lines of schema.org, and different people can extend it easily. And once that's been done, we can then move towards coming up with a common vocabulary for hospitals in the country. We also got asked quite a few questions on what happens for various types of users, either from a point of view of multiple languages, if they need assistance in using these flows, because at India scale, not everyone in a self-service mode. There may be multiple form factors as well, not limited to a smartphone, could be on computers, on someone else's computer, and even beyond that. And how would all of this play out, and who builds these experiences? So we have not very explicitly standardized the front-end experiences in any of this, right? So the back-end interfaces have been standardized, and we expect market participants to innovate to build out either multilingual front-end experiences depending on the user segment they're targeting. One can also have multilingual versions of the dictionaries being built out. The second is people can innovate on assisted flows, right? Where let's say I'm using a teleconsultation in a rural village. Often that you'll have third-party providers come in by truck that has, a bus, and the bus has a whole bunch of teleconsultation equipment connected to the doctor in, say, the city. In that case, how does the patient go on to provide consent? And that's where you can design an experience of the operator assisting the user through a tablet in that journey, right? So this is where we expect entrepreneurs to come in and build out diverse front-end experiences. And this is not new. If you look at various internet standards, be it SIP, for example, or email, right? The core protocol is standardized. And the communication between the different entities is standardized. The piping is standardized. But the front-end experiences is left for people to innovate. So in the case of email, someone may build a client like Gmail, someone may build a client like Proton Mail, offering different functionality. Someone may build something like Superhuman for highly productive email users, and so on. And so we expect that same amount of innovation to kick in out here. So one of the questions was, of course, we got a few questions on blockchain, and one was, have we thought about using zero knowledge proofs between HIPs and HIUs, so that way you can share data without really revealing the user's privacy, theoretically. And currently, the way we look at it, because of the constraints in the blockchain environment, primarily scale, and in this case, it would be complexity of queries that are supported by zero knowledge proofs, because the current set of zero knowledge proofs which have been used in the payments world, Zk, Snarks, and others, are for very limited, very specific queries. The way we've designed it is we don't support zero knowledge proofs in this current version of the architecture. If anyone's interested in actually contributing, please do reach out. I think we're definitely interested in discussing deeper on how it can be added as an extension. But what we do support is a version called query mode of access. So if a user does not want to share their entire longitudinal health record for a particular health interaction, right? And they only want to share, say, the output of a particular test result. In that case, one can define a standardized query language and a standardized set of data filters so that the user, for this particular purpose, can only share those attributes of data and not their entire health records. We haven't yet defined that. So if anyone is interested in helping out, and there are some reference examples, what Professor Nigam Shah at Stanford has done and few others. But if anyone's interested in building out either the zero knowledge extension or the query language extension to this with a particular set of data filters linked with a particular purpose, then please do reach out. The next question is, can validated health data be stored in a more decentralized manner, or either on the user's device or encrypted into whichever cloud service provider of the user's choice? And the answer is absolutely. Again, this is the innovation that can be done by consent managers, right? So if you're a consent manager building out a consent manager app, what you can do is on the front end, actually build out a trusted client, right? And so in that trusted client is where you can store the decrypted user's details and users' health information, right? And so therefore it's physically with the user at all times. You can also offer, as a consent manager app, a way for this information to be encrypted and then passed through any cloud service provider of the user's choice, right? So I could even say, hey, a link, store this in my Google Drive or store this in an S3 bucket, right? And that encrypted information is sent from the user's app, from the user's trusted client to that particular cloud service provider without going through the consent manager server as well. And so that is an implementation that is possible. And we'd actually push the community towards building that out, building out that trusted client and the functionality to then store it in any cloud service provider of one's choice. And there have been versions out there in the market. You can take a look at, say, digi.me, digi.me, which has also implemented a trusted client and then storing it in the cloud approach, and a bunch of other examples. And so that's absolutely supported as an extension on top of the interfaces we've defined. So the next question is, for a doctor who is my primary physician, shouldn't the person have access to my entire longitudinal records rather than having access to a part of it, or are both scenarios taken care of? So the answer is, and this is actually a very interesting question, because there are multiple ways to look at this. There's a perspective of anonymity and a patient requiring anonymity in particular health transactions. Let's say when I'm sharing particular mental health or sexual health information, right? And then there's also a principle of do no harm, where in certain health interactions, the doctor does need to know, let's say, my mental health history in order to prescribe a better protocol of care or better care treatment plan, right, in my interest. And therefore, the way we have addressed this is, this really depends on the purpose of that health interaction, the use case of that health interaction, right? And so you can prescribe data filters for that health interaction linked to that particular purpose that says, hey, for this particular health interaction, I actually only need a subset of your health information, right? Let's say from the point of view of claims processing, right? So in a claims processing use case, your payer only needs access to your health records that were generated at that point in time for the health interaction with that provider, and not your entire longitudinal view, right? So for that purpose, I can share only a subset. For another purpose, before going into a surgery and so on, depending on that purpose, a larger set of information can be shared. So we have kept that completely flexible in the architecture. The next question was, how might public health researchers and others be able to access appropriately anonymized individual level data? And there are two ways to this. One, currently what we've spoken about is only addressing sharing of personal health records with users' consent. And that's because that data is linked with the user's identity, right? So the framework does not cover non-personal data or any information delinked from user's identity. And for that, there is a non-personal data committee that has been put together And so whenever that report comes out, one could take a look at that for answers to questions of access to anonymized data. And then a bucket of that, which is really high level statistics, aggregate information, is already covered under India's National Data Sharing and Accessibility Policy. And it constitutes what's more commonly known as open data, right? So far, what we've covered only addresses sharing of personal health records linked with the user's identity with their consent. In this case, a health researcher may approach individuals or a set of individuals, depending on their sample study, and in a very informed manner, because for a lot of health research, they may actually want the user's identity as a part of that, especially if they're tracking a particular set of users over a period of time and studying them. And once that health research has passed all its approvals, ethics committee, all of that, then they can actually approach users and say, hey, for this authorized study, could you consent and share recurring health information for this particular purpose? So that is one way to access health data for medical research purposes. And this is in fact what's available today on let's say Apple Health Kit. Health Kit allows you to consent and share your health records for a range of medical research purposes. But access to anonymized data, we would not cover, we are not covering at this point in time for research purposes. The next question was, what are the use cases for time-limited access to one's health data, and how does one limit it? And again, this really depends on various interactions. So let's say in the use case of a particular second opinion, the doctor at that point in time needs to go through my health records, but they don't need it for historical purposes. So they go through it, they provide their diagnosis, prescribe the relevant treatment plan, right? And then that interaction is completed. They do not want to store that for, let's say, a longer period of time, in which case, when they raise a consent request, they can actually specify the relevant data life. So the data life could be in the order of few hours. The data life could be in the order of few days, months, and even years, depending on the use case. In some use cases, one does need to store data for the order of a few years, especially for compliance and subsequent audit reasons. So depending on the regulatory paradigm within which the data is requested for, those attributes can be specified when raising the consent request. It is also then shown to the user on the consent manager app, and then the user can either approve it or deny it. And if it doesn't agree with the user can even deny that request if they feel for a non-relevant purpose, the consumer is storing it for too long. And we also had a bunch of questions around the flow and the API, the requests and responses, and the networked requests and responses across the consent manager, the gateway, the bridges, and so on. So we've actually put that together out here. In the interest of time, I won't go through the details of each of this, but very broadly, it covers the linking flow, the consent flow, as well as the data flow. And so we will circulate this deck at the end of the call, and you can share this internally with your teams to get a better understanding of the APIs, and it should make your integration a lot easier. Yeah, that's about it from my end. Over to you, Sharad.
Sid, could you go through one of the flows just to give a flavor of this to the people, because that will help them, pick any one, and if you can go through it, that will be helpful.
Sure. So I'll maybe go through the consent flow. So out here we've, one second, this Zoom is hiding the diagram on my screen. Yeah. So out here we have the user, the HIU, which is the health information user, the HIU app, right? So imagine this is now a user going to a doctor in the clinic, right? And that doctor in the clinic is using an app. Then you have the health information user bridge. So the app that's being used by the doctor in the clinic needs to interface with this network to access data. And therefore, like I mentioned earlier, they interface with the network through an API bridge. And so that app has selected a particular API bridge, HIU API bridge. That bridge has selected a particular gateway, right? And then you have the consent manager app because the user needs to approve consent on the CM app. So now the user, so these are the entities. The user goes to the doctor in the clinic. The doctor says, okay, I need access to your health record information. And so the doctor raises a consent request, which is nothing but the identity of the user at the rate of whichever consent manager is provided by the user, right? So say Siddharth at the rate of NCG, and then other parameters part of that consent request. So what I covered earlier, which was what is the purpose for which I'm asking for this data, for how long, is there any frequency to this data access that's being attached, what is the data that I'm requesting for, so are there any data filters prescribed to it. So all of those parameters have been standardized and then get raised via the HIU app to the HIU bridge. The bridge then, of course, just forwards it to the relevant gateway. And the gateway now, given that it has the consent manager registry, as well as the bridge registry, knows that, okay, the request is coming for at the rate of CM, or in the example I gave, at the rate of NCG. So it knows to which consent manager app it should be routed. And so it routes it to the appropriate CM app. The CM app then shows the consent request to the user, right? Saying, hey, this HIU is asking for it. It shows it in a human readable manner, multimedia or otherwise. And the user can then review this request. These are async flows. All of them are async flows. So yeah, so the user, it then shows it to the user on the app. And so the user then gets a notification saying, hey, this HIU is asking for your data, so please review it. So in the next part, right, the user has been notified and the user then approves that consent request. And all of this is happening in real time. The CM app then sends it back saying, okay, for this particular consent ID, the user has approved it. So it sends it back to the gateway and it sends that relevant information back to the bridge. The bridge is nothing but a forwarding entity who sends it back to the HIU. The consent ID essentially allows for the HIU app, since these are async flows, it allows for the HIU app to check for status, right? Because let's say I'm implementing an assisted experience. So in an assisted experience, the user may actually take a little longer to approve the consent request, even in the order of, say, 30 minutes or an hour, and so on, right? Because the operator would be assisting the user, explaining it to them, and so on. And so the HIU app can manage the UX on their front end by checking the status at some recurring amount of time against the consent ID, right? And once the consent has been approved, the consent artifact is generated within the CM app's environment. And so the CM app then sends that digitally signed consent artifact to the gateway. The gateway forwards it to the bridge, who then forwards it to the HIU. And one set of artifacts gets sent to the HIU. The other set of the artifacts gets sent to the HIP, because the providers need to now receive these artifacts, what I said earlier, verify it, validate it, and then go and fetch the data from their internal systems. Again, since these are async flows, providers may take a particular amount of time to fetch the data, process it, and then serve it back and therefore this is supported in the current V1 of the architecture. And then this was just the revocation flow, but I'll just talk about the quickly talk about the data flow, staying on topic. So just to quickly recap, consent request raised, user approved it, consent artifact generated, one set of artifacts has been sent to the health information user, one set of artifacts have been sent to the health information providers by the gateway, and the providers have now verified it, validated it. So you now come to the data flow, right, where you need to share that. Once a provider has readied that information, it needs to be shared to the health information user app, right? So at this point in time, the HIU initiates the request for the health data, right? So it gets forwarded, and when the request is received by the HIP, it starts the preparation of that health information. And of course, it acknowledges that I'm preparing the health information and sends the acknowledgement back. And then once the HIP is ready with the health data, it pushes it to the endpoint that it received in the HIU's request. So the HIU provides an endpoint, and then the HIP sends the data directly to that endpoint over TLS, sends the digitally signed data back. And it doesn't go via the gateway or via the consent manager at all.
Yeah. So excellent. Sid, we'll take a couple of questions. One of the questions is that if an HIU is aggregating information from disparate HIPs, how would a real-time aggregation work? Because it is quite possible that some HIP or their associated bridge may be down, and therefore partial aggregation might happen. How does the architecture provision or budget for this scenario?
Yeah, that is a good question. The way we see it, and therefore certification is a key part of this ecosystem. The API bridges are certified, and therefore they have to meet certain minimum SLAs. And in the context of this question, they have to meet certain NFR SLAs on availability as well as response times. And if they don't, they would be penalized as well. So that is one. The second is, and so that's one way to ensure that when a request is sent to a particular HIP, their respective API bridge responds back. And in the internet world, for example, certification has played out extremely well. Let's say your Wi-Fi devices are certified and that's a stable connection, or your Bluetooth devices and so on. The second part of it, assuming even a worst case where the certified entity is down for that period, the user does, and again, this is the front-end innovation that can happen, the user pushes their health information to a health vault, right? Because if you look at it over a long enough time frame, which is from, say, birth to death, and I want to store my records over this long time frame, certain HIPs itself may go out of business, let alone their API bridge going down, right? And therefore, we do expect users to say, hey, this information is important to me. And so every health interaction that I do with an HIP, please push a copy of that record to my vault. And that could be whatever vault provider the user chooses, right? And therefore, the next time around, when they're sharing data with an HIU, that data gets fetched from the vault instead of going back to that HIP, which may be a small clinic. So these are the two mechanisms that are available to ensure availability of the data.
One more question that's come up is that, is this access to the test environment and certification, is it available only to people who are part of the SWAST Alliance?
Yeah, so that's not correct. It's not at all only available to people that are part of the SWAST Alliance. It's completely open, and we had sent the links, but I'm just... So these are the links where you can access all the interfaces The test environment, once it's ready, will be published here as well. So just like you have an open source implementation of the gateway as well as of the consent manager app that you can use and locally host, the test environment will also be published on the same repository. So one can access it when it's published and use it to simulate the various test cases against their implementation.
So you are not required to be part of Swasth Alliance, although we do encourage you to consider that, because you will then be amongst people who are also working on the same infrastructure. And we are hoping that, as has happened with other cases, there will be this homebrew computer club kind of an effect where competitors also share tacit knowledge with respect to bugs and hacks or workarounds around those bugs with each other. We've seen that happen for all the other elements that have come up, and we expect this will happen here, and this will be one place where you would be easily able to interact with other players to get hold of the tacit knowledge, but it's not a requirement. So with that, I'd like to thank you, Sid. We are going to answer even more questions in the next session. So don't worry, we will cover everything that you are asking in the coming weeks as we move forward. So with that, I'm going to...
So I had just one more question came to my mind, Sharad, if I could maybe answer that. I remember reading about it, was users' historic health data that may be in physical forms, right? And how do they add that to the network? That is, again, the front-end innovation that could be provided by a consent manager app. So they can facilitate the user to upload PDFs or send it in physically, and then they offer a service for a fee that converts that physical document / PDF into a structured format and then pushes it into the user's health vault. So that we have left to the market to actually innovate and offer as a feature to different users. That's it from my end, Sharad.
Thank you so much, Sid. So we're going to switch gears and talk to you a little bit about the doctor registry in particular. So over to you, Kiran. Thank you.
Thanks. Sid, can you continue to project, or just one second? Yeah, Sid, if you don't mind, can you continue to project the slides?
Okay, one.
So, good afternoon, everyone. So I'll try to cover health stack and the concept of electronic registries in the health stack. The core idea is that all of these health information flows and many other use cases when we consider digital health require actually very strong master data. If every system is trying to figure out which are the facilities, how to identify them, who are the doctors, how to identify them, what's the right way to identify a patient, and so on, it's not going to be very effective to build an interoperable ecosystem that actually can work together on health data. So the health stack actually recommends that master data for various entities in the ecosystem actually be built into registries. And there's a whole bunch of design principles that are recommended as part of that, especially in terms of how do you make sure that the data in a registry can be really trusted, how do you make sure it's non-repudiable data, how can it be maintained because data keeps constantly changing, and how does it get access to different players or actors in the ecosystem through open APIs, and how do we, of course, continue to keep the construct of consent even in registries. So because registries are likely to contain some information that's going to be public and some information that's going to be private, and just like for personal health records, we are saying that the user is in control of the data and the user decides who he can share the data with and what he shares. A very similar thinking is the recommendation on application for electronic registries. Sid, next slide, please. So if you look at the National Digital Health Blueprint, the National Digital Health Blueprint, that committee also looked at what are the kind of entities for which, say, registries or directories. So the digital blueprint uses three terms, right? It uses the word registry, it uses the word directory, and it uses one more term that I'm missing right now. But fundamentally, for defining the construct that in the national health stack we have been calling as registries, and it includes about how do you identify, say, a patient or a family member, how do you identify care professionals, providers, payers, governing bodies, and so on. And you should visualize that these are about how these entities become visible or available from a digital ecosystem perspective. But doing a good job on creating one will also help in many other things, especially on the policy side. And so we'll talk a little bit more about, for example, when it comes to doctors and doctors related data. Today, for example, in India, we wouldn't have very good or very strong data that's maintained in the government on specific fellowships or specializations that have been done. It's very good till the MBBS layer, but depending on the state and the state medical councils, it kind of starts to drop away. So the other recommendation is to use this opportunity of the fact that you're creating something for the digital ecosystem to also build stronger quality of metadata. The same is true for example, providers and care providers. Different insurance companies constantly collect what are the capabilities of a hospital in a variety of paper formats, but a strong, simple digital format that is commonly shared by the industry would reduce the pain on both sides and also make sure that the information being collected is absolutely machine readable and reusable. So those are the kind of benefits that would come if we can actually do a proper registry for the digital health ecosystem for many of these. Next slide, Sid. So these are some of the design principles for registries. And one of the first thing it says is there should be some amount of self-maintainability. So you can think about a hospital or a doctor who have a digital entry in a registry. There are many elements of their information that they should be able to update and keep it up to date. And there will be, of course, several elements which are needing to be verified. So one is the fact that it needs to be self-maintainable. The second is it has to be non-repudiable. So for any entry in a registry, we should be able to say what was the source. Is this a self-declared element? Is this something that's been verified by an authorized entity? And who made the change? When did they make the change? And that's really what the non-reputability part is. Clearly, our recommendation has been that registry should not attempt to store every possible piece of data that's possible on an entity. In fact, there has to be a kind of a demarcation on what's public and what's private, and also how to layer this so that only minimal information is stored in, say, a government kind of a registry, and there is ability for the ecosystem to actually build on that. And that's what the layered access as well as extensible schema construct talks about. And in any digital ecosystem, it's one of the most important things is that registries have to be enablers with open APIs for the ecosystem to be able to use it to build all of these digital health information flows that we are talking about. Much of the data on say doctors or facilities are available with many entities in private and in the government, but they're absolutely locked up either on paper or in systems that are not interoperable. So one of the biggest things that we are hoping for with the registries is to actually have an open API architecture and an interoperability that will help build and act as a base layer for the ecosystem. Now, our own belief is that no registry will be successful unless there are enough use cases that helps adoption and helps keep these registries up to date. So it's very important that the design try to make sure that there are enough incentives and there is incentive alignment for adoption. So in today's discussion, there has been a little more thinking on one of those registries, which is the doctor registry. So I'll use that as an example to see if I can articulate how some of these design principles are being applied. Sid, you can move forward. So here is a construct which talks about how layered information would be handled. So for example, if you take a doctor registry which is managed by the government, we would expect that demographic information, medical registrations, education details, etc. would be part of the base layer. But things like what are the work hours of a doctor, what is his consultation price, what are the ratings would be something that would be managed by the ecosystem. But even this layer, which may be managed by some ecosystem player, would have to be available to applications. And we do hope that it evolves into something where there are consistent API signatures and the schema structure is extended so that the benefits of doing this will actually come into the ecosystem. And so we do see this as, again, Sharath uses a jugalbandi that hopefully between some contents coming in from a public digital infrastructure, which then is enhanced and used by the private ecosystem to actually create more value for the ecosystem. Sid, next slide. Now, one thing that we do believe is that it is not easy to create high quality master data for any registry. It does require a lot of thought, good design, and an effort by the organizations that are going to have to actually create this. And I've just used an example of the doctor registry to kind of understand how every information would probably need to be verified so that you're sure that the information being captured, presented, and whether it's public or private is something that can be trusted. So medical registrations may need to be going back to tie-ups with state medical councils, which actually validate that yes, indeed, this is a right number. Things like mobile and email should ideally be always be verified through some kind of an OTP. Say demographic information could be verified using something like an Aadhaar, eKYC as an example. And say even PAN today can be verified, say things like with NSDL APIs or other APIs. So very important that every registry takes a very conscious look at what is the minimal data it's keeping and how does it ensure that each element of this data is something that's strongly verified, or you can really trust the data. And also it provides this non-repudiability, that it's clear that as to what's the source of the data as well as how it was verified. That's it, move forward. So we talked about how incentive alignment is key to adoption. And this is the current thinking that we have heard on what the doctor registry would do. So the first and foremost question would be that if there is an entity who's going to be part of a registry, what is their motives to become part of it? So why should a doctor say that I will actually become part of a doctor registry, and what is their motivation to keep that information up to date? We understand that the doctor registry is going to be an entity that will enable doctors to actually easily participate in the digital health ecosystem. So being part of the registry will help them do things digitally, for example, sign prescriptions, e-sign prescriptions, or diagnostic reports or discharge summaries, and claim documents from just their phone or from web. The fact that there is strong verification would mean that probably online apps can do something like a verified symbol. But there have been other use cases that have been talked about. So can we help doctors collect CME points online? Can they get online services from state medical councils? We came across a use case where doctors who buy professional indemnity insurance, and I believe the insurance price changes based on what is your, whether you're a general physician versus a neurosurgeon, and you need to prove that you are a general physician or a neurosurgeon. So an eKYD kind of a service would make that move from being a completely paper-based process today to a non-paper-based and a digital process today. So these are examples of how certain use cases based on these APIs and others that would be offered on the top of a registry would actually help these registries to be adopted and used in the ecosystem. Sid, can you go next? So I'm just going to use some of the kind of APIs as an example. We don't yet have the APIs for the doctor registry in public, and from Sharad, I understand that we are looking for something in early June for that to be put out for feedback. But some of the kind of examples of APIs that we expect that the doctor registry would have would be, for example, as simple as get public information. Every registry is going to have certain information that is public, and you would have APIs that would help you quickly and rapidly look up that, including say the verification status of that record. You would have an eKYD or a know your doctor kind of an API. So if, for example, an application wants to e-sign documents, have a doctor onboarded who would e-sign their documents in their application, it would be a consented access to be able to fetch some of the information from the registry, which would be then available to that partner for being able to do that. Of course, the big benefit of the registry is the ability to rapidly e-sign different elements in the digital health ecosystem. So that would also be there. And not only would we are also expecting that there would be onboarding APIs, which essentially would mean that partners in the ecosystem could build front ends that would help doctors to actually enroll themselves in the registry, apart from, say, the UI that's offered by the registry itself. Thus enabling more experiences and better user experiences in the ecosystem. So this is how we see all of this kind of play out, starting with a few key registries in the beginning. We do think that the doctor registry is one of them that's we are seeing good progress happening on, and we hope that other registries will get built with the same design principles and come out over time. Sid, next. I think I'm done with my presentation. Yeah. Thanks, Sid. Sharad?
So we are on time. There aren't very many questions on the registries yet. So I don't see anything that we need to answer right now. Our next session will be at the same time next week. We will continue to answer your questions on PHR and doctor registry. We want to answer almost every question that you have, except for the business model, business incentive questions, which we will take up much later. So if you have any questions, please respond on that link that was shared with you for Q&A. Please add them there, and we will see you again next week and look forward to the next third open house session. Thank you so much.